Mr. Stark is recognized.
Thank you, Mr. Chairman. Thank the witnesses for participating with us today. Mr. Nichols, you talked about why public and private payers must work together to align incentives. So while this hearing has been informative, it seems to me that the focus just on private sector initiatives misses a larger picture. Could you talk some more about the need to combine the public and private sectors and to see if we can get those stars in alignment?
Be glad to, Congressman Stark. Basically, the simple reason they have to cooperate is because most clinicians treat all kinds of patients. And turns out, in lots of specialties cases and in some locales, a majority of a clinician's patients might be public. So they're the biggest market share. They're typically the biggest market share for hospitals, and they are often also so for specialists, including cardiology, I might point out. So if you don't get the sectors aligned, if you don't get the incentives aligned, clinicians are going to be both confused and, as Dr. Bender might say, unhappy about it. And so the best way to transform patient care is to get them aligned. That does not mean they all have to pay the exact same level. I certainly believe in the private enterprise system. I certainly believe in competition. But I also think it makes sense for them to have the clinicians to face the very same set of incentives, the very same set of feedback loops, the very same set of metrics. The very idea that United would have one set of metrics and Aetna a different one and Cigna a third and Medicare a fourth and Medicaid and yada, yada, yada. By the end of the day, what's the clinician going to do? What they think is best independent of what they're being paid by. So the smartest thing to do is to get the incentives aligned. Now, there are lots of reasons that's difficult to do, but there's about 300 million reasons it's a good idea to do as soon as possible.
Thank you. Also, it's my understanding that we are probably the only industrialized nation that does not use a comparative effectiveness measure. And I hasten to point out that all the comparative effectiveness programs, whether they're for pharmaceuticals or medical procedures, don't include cost. And of course, there is this, for some reason, I think it's mostly political fodder, but people are suggesting that using comparative effectiveness would lead to rationing. And I'd wonder, both Dr. Sandy and Dr. Scher, what's your reaction to that? Is comparative effectiveness, if you had that available to you across the board? Some professions or segments, thoracic surgeons, for instance, have done their own for, what, 5 or 7 years. They've collected data on every procedure that every member of the club or college, or whatever you call it, has provided to a patient and the outcome, and they've tracked the patients. But that's a small group in the firmament of medical providers. What do you think about the rationing issue?
Well, thank you, Congressman Stark. The comment I would say around comparative effectiveness research is it is absolutely essential that there be investments in understanding of the differences in clinical effectiveness between different treatments so that physicians can have the best science and information to help inform the choices and their care, and that patients then can have that information as well so that they can make their informed choices. I think what I really would underscore and echo and support is the phrase that Dr. Lewin laid out. He used the term bringing science to the point of care, and I would strongly support that. And I think organizations such as the American College of Cardiology, the Society for Thoracic Surgery that you mentioned, these medical specialty societies are really at the forefront of doing that. One of the things that, in my opinion, would be helpful is these societies are at the forefront, but there are other societies that would like to move in this direction to develop detailed clinical registry information to help inform the physicians that are part of that specialty area to collect that information. That's been a challenge, and it is gratifying. There is a fledgling effort, by the way, called the NQRN, the National Quality Registry Network, a multi-stakeholder coalition to advance this frontier, and we think that would be very important development to support.
If I may just have another second, Mr. Chairman, wouldn't the requirement for keeping electronic records, which now everybody is supposed to do, help toward this, building this comparative effectiveness study?
Well, again, one of the things that your question points out is the issue of the challenges of administrative simplification and the fact that many physicians do not have electronic health records. While electronic health records sometimes aren't architected to collect detailed clinical information, it is an important start to help promote that kind of data collection for the purposes that I've outlined.
Thank you.
Mr. Chairman, could I just add a brief note in response to Mr.
Very
Stark's question?
quickly.
Yes. So we've actually embarked on a very ambitious approach to empowering the provider community in the spirit of our partnership approach with the workings of comparative effectiveness research, putting them into the hands of the provider community. We have 17 distinct hospital-based, multi-institutional, data registry-driven, collaborative quality improvement programs that have dramatically decreased the rate of mortality and morbidity and saved money while doing so. And we're now in the process of linking claims data to the quality data across the state to empower CFOs, CEOs, and physician leaders to use that integrated data set to improve value in hospital care.
Thank you.
Mr. Johnson is recognized.